Hello, everybody. Thank you to this e-cancer event. We are here right after ASCO 2021, which I think was great for GNU in general and for prostate cancer specifically. I'm Karim Fizazi, medical oncologist at the Institut Gustave Roussy in Villejuif in France. I'm delighted to be here together with colleagues and friends, to be honest. So I have Laura Maria Krabbe from Germany, Alicia Morgans from the US, and Neeraj Agarwal also from the US. So we're here today to try our best to summarize the data that were shown at the Congress regarding treatment for men with metastatic castration-sensitive prostate cancer. And it's true that the field has changed dramatically in the last 5 or 6 years. Sometimes we're lost, to be honest, but it's good. It means that we are improving patients' outcomes. And of course, it generates a lot of debate, which again is very important. So let's start with one of the papers which was shown at the Congress at the oral session by you, Neeraj. And this is an academic phase 3 trial looking for the first time at alterna or TAC700 in men with metastatic castration-sensitive disease. This was conducted by the cooperative group, the SWOG group, and this is the first time we see the data. So can you please remind us what was the design and what are the main data?
First of all, it's such an honor and pleasure to be here with my esteemed and respected colleagues who I always look up to in my career. So thank you for the invitation. SWOG 1216 was a NCI-funded cooperative group trials where patients were accrued by SWOG, Alliance, ECOG, and basically the cooperative groups funded by National Cancer Institute. In this trial, we hypothesized that combination of ADT plus TAC700, which is a specific CYP1720 lyase inhibitor and does not require prednisone at the doses it was used in the trial, will improve overall survival compared to standard ADT plus bicalutamide in men with metastatic hormone-sensitive prostate cancer. So the trial enrolled around 1,300 patients, 1,279 men to be precise. The primary endpoint was overall survival, and secondary endpoints were progression-free survival and PSA responses. At the time of final analysis, at the time after a median follow-up of 57 months, the median overall survival was 81 months with TAC700 versus 70 months with bicalutamide. However, an improvement of 11 months in the median overall survival did not meet the pre-specified criteria for statistical significance. Other endpoints also favored TAC700. So we were intrigued why it happened. It's a very strong survival benefit with TAC700. And the control arm actually did much better than expected. We estimated control arm survival would be 54 months. It was 70 months. So 16-month improvement in control arm and 11-month improvement in overall survival with TAC700, all great news. But statistically, it was not positive. So we decided to do a post-hoc analysis. And we found that the life-prolonging subsequent therapies were received by 77% patients on the SWOG 1216 control arm, which may have resulted in an absolute median overall survival of 70 months, which is, by the way, the highest ever reported for men on ADT alone arm of all contemporary trials in MHSPC. If you compared the median overall survival of men on SWOG 9346 trial reported by Dr. Maha Hussain in 2013, and which basically included all patients with standard ADT only, the median overall survival on the standard ADT arm was 46 months. So compared to SWOG 9346 trial, which also, by the way, had similar number of patients with extensive risk, so exactly the same number, the survival was 46 months. So basically, survival of patients with hormone-sensitive prostate cancer has improved from 46 months to 70 months in the US. So we concluded by saying that result of 1216 reported a great news for our patients with newly diagnosed metastatic hormone-sensitive prostate cancer. And these results show that early intensification of ADT in metastatic hormone-sensitive prostate cancer, in combination with access to life-prolonging therapy in metastatic CRPC, is likely going to lead to unprecedented overall survival benefit in our patients who are being diagnosed today. So this is how I would conclude my trial results.
Thank you so much, Neeraj. So on the one hand, it's a negative trial, but it's also informative of a current situation with probably better outcomes for patients as compared to what we used to see in the past. Alicia, what do you think about this data, and what do you think is going to be the future for alterna in this space or in other spaces? Tell us what you think.
Sure. Well, thank you for asking. And of course, thank you for the invitation. I think that alterna, unfortunately, is not a drug that I anticipate will be moving forward in ongoing development. And it actually, of course, as we know, has been assessed in the metastatic CRPC setting and already has not been developed in that setting due to a separate trial. But I do think that Neeraj's point about the control arm in this particular setting and the way that we have really shifted the survival curve for patients with metastatic prostate cancer in the last decade is probably what this is reflecting, is phenomenal. And as he said, that 16-month longer than predicted overall survival, I think, is just a testament to the work that's been done. I am really happy to see this data because patients who are in this setting, who have metastatic hormone-sensitive prostate cancer, sitting in the clinic will say to you, well, what is my life expectancy? And this is, of course, assuming that they get the treatments that we know we want to give to them. And now I think we have a way to estimate that. And that, I think, is one of the biggest benefits from this trial.
I fully agree. And, just to put this into perspective, just 2 decades ago, men in this setting with metastatic hormone sensitive basically had about 1 year to live before progression, and then a total of, say, 3 years just to live. We have made tremendous progresses, and this is what Neeraj's trial basically confirms and shows very beautifully. Excellent. Laura Maria, any other comment on this trial?
Well, I would obviously agree with what Neeraj and Alicia have said before. And unfortunately, also for me, I don't think that TAC 700 is going to move forward to where we can use it in practice in this setting. However, to the point of the control arm being so good, we have probably to discuss about what our endpoints for trials are going to be, because if we have so many effective treatments out the back, maybe overall survival is not something that we can count on reaching in the future. That's one thing. And secondly, I would want to congratulate Neeraj because this was a trial where for probably the first time ever, a significant number of patients of minority ethnic groups were included. And I thought that is a point where we are talking about for quite some time, but this is the first time that we see a relevant proportion of minority patients included in this trial. So thank you so much, Neeraj, for contributing this to our whole prostate cancer community.
Right, thank you very much. So basically, I think we all agree that we should now intensify treatment for men with metastatic castration-sensitive disease, at least to make it easy, those with de novo disease. I guess there's still some debate here and there about patients relapsing. And this is because we saw in the last 5 or 6 years, positive trial for the Taxol, for next generation hormonal therapy, and also for local radiation therapy directed to the primary in men with oligometastatic disease. The big question is how best should we combine all these treatments on top of ADT, and actually should we really combine these treatments? And this is exactly the question. The second trial that was shown at the oral session, Piece 1, is actually trying to address as a question. So Piece 1 enrolled almost 1,200 men. This is also an academic trial, collaboration between 7 countries here in Europe. And those men received standard of care, which consisted in ADT alone at the beginning of the trial, and then we moved to ADT docetaxel when docetaxel was shown to improve overall survival during the second part of the trial. Most patients in the trial received actually ADT docetaxel, and the randomization was, it's a 2-by-2 design, so the randomization was for standard of care alone, or standard of care plus abiraterone, standard of care plus radiation therapy, or standard of care plus both abiraterone and radiation therapy. So currently, with the current follow-up and the number of events that we have in the trial, we were able to report data about radiographic progression-free survival, which is one of the two co-primary endpoints of the trial, for the abiraterone equation. For the radiation therapy equation, we will need a longer follow-up because we're focusing mostly on men with oligometastatic disease or low volume disease, whatever you call this situation. But for now, what we saw was at ASCO was data regarding abiraterone on top of ADT plus docetaxel. So should we use 2 drugs only, or should we move to 3 drugs? And the answer when it comes to radiographic progression-free survival is clearly in favor of adding abiraterone. The median rPFS was 2 years in the control arm with ADT plus docetaxel, and it was 4.5 years with the triplet treatments with abiraterone added on top of ADT plus docetaxel, with hazard ratio of 0.5 and a very highly significant p-value. We also looked at various means at assessing PFS, counting PSA or counting symptoms, and what we found was basically exactly the same thing and the same delta, big difference, 2 years or 2.5 years of absolute difference between the two arms. So there's, I think, no doubt that for PFS, even including or using a sharp or hard endpoint, there is a benefit at adding abiraterone. The second good news that we saw in the trial was that during the 6 first months, we don't see much added toxicity from abiraterone. Actually, neutropenic fever is the same, 5% in both arms. Some docetaxel side effects are actually even mitigated, perhaps thanks to the prednisone. And the toxicity of abiraterone is as expected, with 12% hypertension versus 8%, so nothing big. Of course, we need to be cautious and see longer-term data regarding toxicity. With this, I'm happy to ask you the question, because that's much more important than my own opinion. So, are you prepared to change your practice based on this data? Should we wait for overall survival / quality of life data? Or do you think this is sufficient to change at least for some patients? Maybe Alicia, if you don't mind.
Sure, and really I want to also commend you and Neeraj for a fantastic discussion, not quite a debate exactly, but a wonderful discussion at ASCO between the two of you, of course, and then Silke Gillison and Lisa Horvath on this particular topic, because I think that there will be a lot of answers that may be nuanced, not just between clinicians, but also, as Neeraj mentioned, between patients who will or who will not be interested in really intensifying. I think that the debate regarding progression, particularly because this is radiographic progression, which in many cases is symptomatic, at least in terms of anxiety, if not in pain, I do think that there will be patients who are interested in trying to access abiraterone after initial treatment with ADT and docetaxel. I also think that this will be different depending on where you live. And certainly, even within the US, there are regions and groups that want to do more and others that really want to see that final overall survival data before immediately jumping into another treatment. And of course, this is going to vary around the world and depend on financial toxicity as well, which can limit people's access to therapies. So at this point in time, this is a conversation that I will have with patients, and I look forward to hearing how different patients will fall out on different sides. And I also look forward to the survival data and the biologic data that's going to help us understand whether there may be subgroups within this cohort, that may benefit more or less, but very eager to hear what others have to say.
Thank you very much, Alicia. Aloha, Maria, what do you think?
Yeah, thank you so much. So, I mean, congratulations. This is a fantastic trial, and Obviously, so to me, I think the biggest message is how underscored the added value of abiraterone is in this setting. Because, I mean, obviously, the latitude population was a little bit more specific because it was only high risk, all de novo as in your trial. And then from Stampede, we also have long-term data, how big the effect of the addition of abiraterone is in basically a whole variety of patients. And I think this study adds to this. With the regard of will I use the triplet, I'm quote unquote in a little bit of a pickle because for your trial, and that's very understandably, you changed your standard of care after the coming out of the Charter trial to ADT plus docetaxel. However, the current reality in at least my country, where fortunately we have many options available, is that the standard of care is usually ADT plus a new hormonal agent. So abiraterone, apalutamide, or enzalutamide, which was currently approved here too. So for me, the question is, does then the addition to that standard of care with docetaxel will derive a benefit? And unfortunately, and that's just part of the design, this trial cannot answer this. Will I still talk to patients about the triplet? Yes, I will. Because I think there are certain patients, very young, very risky disease, et cetera, where, you know, I probably, or you guys too, had the feeling for a long time that the triplet might benefit these patients. But I think overall, the added value of abiraterone in such a variety of patients is underscored again and again, including your trial here. And it's a little bit sad almost that the approval in de novo high-risk disease of ABI will probably not change here, despite us knowing that it could benefit so many more patients.
All right, thank you. Neeraj, you have the last word regarding this question of triplet versus doublet. What do you think?
I agree with everything what was said just now by dear friends Alicia and Laura Maria. You said it so nicely, so put it together. I just want to add here one thing. In my view, castrate-resistant metastatic disease phase is the symptomatic phase of prostate cancer or metastatic prostate cancer. I try my best always to delay that phase of the disease, and anything I can get hold onto which will allow me to do it for my patients, I will look forward to. So if this combination is available in my clinic, I will discuss this combination with my patients. I will present the data like I do. In my clinic, patients make the decision. My job is to help them make a decision. And if patients want to get this triplet as a treatment, I will be very happy to offer. So that's my take, number one. Number two is, it will be a nice segue to what we are going to discuss next. We need biomarkers to stratify patients who are at the highest risk of disease progression and death. And I think this triplet combination and other coming up soon, hopefully next 1 or 2 years, will allow us to give something beyond monotherapies and doublet therapies to those patients who are at the highest risk of disease progression and death. So I think we need to find biomarkers to identify those patients. So thank you.
Absolutely. Thank you so much. Okay, let's move to another phase 3 trial, Titan. We saw the data already for the primary endpoints, and obviously this is another positive trial for overall survival. But here at ASCO, we saw the very first data for quality of life, I believe. Alicia, can you summarize them to us and tell us what you think?
Sure, of course. And just to acknowledge that this is the data for metastatic hormone-sensitive disease, ADT plus APA versus ADT placebo. And this is the longer-term follow-up, so about 44 months of median follow-up here. It was very important, I think, that what was demonstrated in terms of quality of life is that patients continued to feel well. And patients on the combination arm did not report worse quality of life overall. They did not have more pain. Interestingly, there was actually similar quality of life and pain control, it seemed, in both arms. And importantly, I would say patients actually completed their quality of life metrics. And this was done at a high rate, even with this much longer term follow-up, which is important, and also the patients as well as the investigators should be commended on encouraging patients to do that. There did seem to be a little bit more fatigue in the patients who were treated with the placebo rather than apalutamide. But in general, this patient population maintained a good quality of life. And that, I think, is what we all want. And as Neeraj said, if our goal is really to prevent the symptomatic portion of the disease process, which really in many cases comes at metastatic CRPC, this drug was able to do that.
Absolutely. Thank you so much. Laura Maria, I think we also saw data from another phase 3 trial, Arches, which is assessing enzalutamide, another positive trial, at least by RPFS. And we saw an analysis for men with low burden disease, oligometastatic disease. Can you tell us what was reported and what you think about the data, please?
Yes, thank you so much. So this was a post-hoc analysis of Arches, as you already said. And in Arches, again, Enza plus ADT was tested against ADT alone in patients with metastatic hormone-sensitive prostate cancer. And because this was an all-comer population, so there were patients that had a small amount of metastases or many, and they could be newly diagnosed, but also have a recurrence. The question obviously is, well, is the effect of the addition of enzalutamide different with regards to tumor burden? So in this post-hoc analysis, it was looked if the presence of one metastases, 2 or less, 3 or less, 4 or less, 5 or less, or more than 6 would be different with regards to the effect size of the addition of Enza. And we saw that throughout those groups, so different tumor burden as in number of metastases, it was the same effect size almost for the addition of Enza for the endpoint radiographic progression-free survival, which is the primary endpoint of this trial, time to PSA progression, time to castration resistance, and also time to initiation of new antineoplastic chemotherapy. And so in the clinic, we ask ourselves often, well, this patient has a low burden of disease. How much is his benefit from giving an intensified combined therapy from the beginning? And this post-hoc data would encourage us to use this in all levels of tumor burden.
Absolutely. And actually, this is supported by other analysis with the other NHT treatments, showing pretty much the same degree of efficacy in low burden versus high burden disease. So this is important. Of course, you need to balance the toxicity, the cost, and all these things, but they work. So we're about to finish, but let me ask you maybe one final question with maybe a brief answer from you guys. We also saw, one big thing at the ASCO, which was for the first time positive data with lutetium PSMA, which actually was invented in your country, Laura Maria. So congrats for this. And basically, this treatment is now moving, at least in trials, in this metastatic castration-sensitive space. The trial has started. So tell me what you think about the potential and the rationale of this treatment. And actually, do you think eventually the trial will be positive? Maybe let's start with Neeraj. Just brief answer. Do you think it's worth it testing a lutetium PSMA in MCSPC?
I think it's worth it. There are always going to be patients who need more intense therapy than what we have right now. Yes, we have optimized, we have improved survival of patients with MCSPC. We have not cured any of them. So I think we will continue to work with newer drugs, novel agents. And lutetium to me is one of those agents.
Okay, thank you. Alicia, do you agree?
I completely agree. I think that the way that these mechanisms can work synergistically, I hope, you'll have ADT plus, I believe, the investigator's choice of an AR-targeted agent plus lutetium versus ADT AR-targeted agent alone in the trial that I think you're referring to. I think that we'll be attacking from multiple different angles. And I really do think that that will give us the benefit we need, besides the fact that we've moved lutetium from a very heavily pretreated population, as was presented in Vision, into an earlier setting where everything seems to do better.
Okay, thank you so much. Laura Maria, last word about PSMA lutetium in this space from a German lady. What do you think?
Thank you. So obviously it's good that we now have a trial that reflects the experiences that we have had here with this drug already for a longer time, because we had off-label access to it. And I'm also intrigued to see what it can do in the earlier disease spaces, because it's a new mode of action that we have not in our armamentarium beforehand. And also, I think that PSMA is expressed in the overwhelming majority of prostate cancer cells. So having that to target the effect size that can reach in combination with other drugs is hopefully very good.
Excellent. Thank you very much. I think it's time to stop this event, but I would really like to thank you for participating. And I really hope to see you again at the next Congress, maybe physically, maybe after the summer, we'll see. But thank you very much. I really enjoyed it. Thank you.
Thank you.
Thank you.
Thank you.